Pain relief for advanced pancreatic cancer, celiac plexus neurolysis. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been diagnosed with pancreatic cancer and is struggling with severe pain that even strong medications can't fully control, you're in the right place. I know that when you're watching a loved one in pain or experiencing it yourself, it can feel overwhelming and frightening. But today we're going to talk about a specialized procedure called celiac plexus neurolysis that might offer significant relief. The celiac plexus is a dense network of nerves located in your upper abdomen, sitting right in front of your aorta at the level of your first lumbar vertebra. Think of it as a major nerve junction box that transmits pain signals from all your upper abdominal organs. When pancreatic cancer develops, tumors often sit extremely close to this nerve network, which is precisely why pancreatic cancer pain has that characteristic gnawing quality that radiates from the upper belly through to the mid-back. Celiac plexus neurolysis, CPN for short, uses a chemical solution, typically dehydrated alcohol at 95% concentration, to permanently block these pain pathways. This matters to you personally, because unlike temporary pain relief from medications, this procedure aims to interrupt the pain signals at their source. CPN works by chemically destroying the nerve pathways within the celiac plexus that transmit pain signals from your pancreas to your brain. The procedure can be performed in several ways: percutaneously with CT or fluoroscopic guidance, surgically during an operation, or most commonly now under endoscopic ultrasonography, which we call EUS. During EUS-guided CPN, a specialized endoscope is passed through your mouth into your stomach, allowing doctors to visualize the celiac plexus with ultrasound and precisely inject the neurolytic solution. These chemicals destroy the nerve cells that transmit pain signals. Multiple studies have demonstrated that CPN is more effective than pharmacologic therapy alone for both immediate and long-term pain relief. The reported success rates range from 50 to 80% across numerous studies. In one randomized trial, patients who received early CPN experienced better pain control, consumed fewer opioids, and had fewer opioid-related complications like constipation and sedation compared to those who waited until after medications failed. The pain relief is typically greatest during the first 3 months after the procedure, with the largest benefits seen in the first month. CPN significantly reduces opioid consumption. In a rigorous randomized trial involving 96 patients with unresectable pancreatic cancer, those who underwent neurolysis consumed substantially less morphine. The difference at 1 month was nearly 96 milligram equivalents less per day. Now, what does this look like in daily life? That's the difference between being heavily sedated, constipated, and struggling with mental fog, versus maintaining better alertness and quality of life. Early referral for CPN also meant fewer opioid-related complications overall. The research demonstrates that early celiac plexus neurolysis provides not just better pain control and less opioid consumption, but immeasurably better quality of life compared with waiting until medications fail. Where local expertise is available, CPN is generally preferred over radiation therapy because relief from pain comes faster. Radiation can take several weeks to achieve its maximal effect, while CPN can provide relief much sooner. CPN is particularly valuable for patients with unresectable pancreatic cancer, meaning cancer that cannot be surgically removed, who are experiencing moderate to severe pain despite opioid medication. This includes patients with locally advanced disease confined to the pancreas region, as well as those with metastatic disease where cancer has spread beyond the pancreas. The key is pain that's not adequately controlled with narcotic analgesics, or situations where opioid side effects are severely limiting quality of life. Historically, CPN was most commonly performed either during surgery if the patient was found to have unresectable disease at operation, or percutaneously using CT or fluoroscopic guidance to place needles through the back. More recent experience demonstrates that endoscopic ultrasound-guided CPN offers several advantages. It can be performed during the same endoscopy used for diagnosis. It provides excellent visualization of the celiac plexus, and it avoids needles through the back. There is also a related technique called splanchnic nerve neurolysis, which targets the nerves before they join the celiac plexus. Some studies have raised questions about whether sympathetic neurolysis might impact survival. In one retrospective study comparing patients who underwent CPN versus those who didn't, there appeared to be shorter survival in the CPN group. However, and this is critical, the CPN group had more advanced disease to begin with greater weight loss, higher opioid use, and more severe pain at presentation. The medical consensus is that these findings are not definitive. The trials weren't designed to measure survival as a primary outcome, and the differences likely reflect disease severity rather than the procedure itself. Early celiac plexus neurolysis, meaning performing the procedure before exhausting all medication options, provides superior pain control, requires less opioid consumption, and results in better quality of life compared with waiting until strong opioids have failed. This early intervention approach represents a fundamental shift in thinking about pancreatic cancer pain management. Rather than viewing CPN as a last resort, current evidence supports considering it proactively when pain is moderate to severe, particularly if the patient is already requiring substantial opioid doses or experiencing limiting side effects. If you or your loved one has been diagnosed with unresectable pancreatic cancer and is experiencing pain, schedule a specific conversation about celiac plexus neurolysis. Come prepared with these questions. Am I a candidate for celiac plexus neurolysis based on my tumor location and stage? Is endoscopic ultrasound-guided CPN available at this institution, or would I need a referral? What is the success rate in your hands with this procedure? How does my current pain level and opioid requirement factor into the timing decision? Don't wait until pain becomes completely uncontrolled. Early referral is associated with better outcomes. You should request evaluation by an interventional pain specialist or gastroenterologist experienced in EUS-guided CPN if you're experiencing gnawing epigastric pain that radiates to the mid-back despite taking around-the-clock opioids. If opioid side effects like severe constipation, sedation, or confusion are limiting your ability to function, or if you find yourself needing progressively higher doses of pain medication with diminishing relief. The ideal time for this referral is when you're on regular scheduled opioids but still experiencing pain between doses, not when pain has become completely intractable. Maximum pain relief usually occurs within the first month after CPN and typically lasts for approximately 3 months. Some patients experience longer-lasting benefit, while others may require repeat procedures. Opioid requirements often decrease substantially within the first month, though most patients still benefit from some baseline pain medication. Recovery from the procedure itself is usually quick. Most patients are monitored for a few hours after endoscopic CPN and can go home the same day. If you already have a biliary stent or are scheduled for endoscopy, discuss performing CPN during the same procedure to avoid additional interventions. If you're supporting someone through this, understand that their pain has both a physical and emotional component. Pancreatic cancer pain is often described as relentless and exhausting. If they're reluctant to consider another procedure when they're already going through so much, reassure them that CPN is performed under sedation and doesn't require general anesthesia in most cases. The potential benefit months of improved pain control with reduced medication burden can mean more alert time with family, better appetite, less constipation, and improved overall function. These aren't small gains when time is precious. Celiac plexus neurolysis interrupts pancreatic cancer pain at its nerve source, offering substantial relief for many patients while reducing dependence on opioids. Your next step: ask your oncologist specifically about early CPN referral if pain is impacting daily life. This information is for education. Always discuss your individual situation with your healthcare provider. I have outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.